Hi, this is Stephen, and in this video we will discuss aortic stenosis as evaluated with echocardiography. We've already touched on this in some of our previous videos when we talked about the continuity equation, for example, but let's put some of that information together here. So we'll start with our peristernal short axis view, and in that view we'll see the aortic valve right in the middle as Mercedes-Benz. I'm drawing the pulmonic valve there, the tricuspid valve over here, the right atrium, the intra-atrium septum, and then the left atrium. And this is a nice view to look and see the morphology of the aortic valve. Sometimes you may see an aortic valve that actually is unicuspid. You may see an aortic valve that is bicuspid that looks something like this. You most of the time will see a tricuspid valve right in the middle, as I drew in the peristernal short axis view, or you may see a quadricuspid valve. And as you might imagine, with the quadricuspid valve, you often have problems with leak in the middle. With the bicuspid valve, you may have both the valves that get stiff too early and some leak issues, similar problems with the unicuspid valve. Now, with a valve, whatever type it is, how do we quantify if it is too stiff or too stenotic? Well, we will turn to our apical four-chamber view. Let me get some additional space here. So in our apical four-chamber view, we have our left atrium, our left ventricle, right atrium, and we'll tip it. So we can also look at the LVOT and the aortic valve, and we can drop our continuous wave Doppler, and we'll get a graph of velocity in meters per second over time in seconds. And let's say that our Vmax here is 4 meters per second. And let's say that the velocity time integral, or VTI, the area under the curve, let's say that that is 100 centimeters. We can similarly use our pulse wave Doppler to measure the velocity, not along the whole line like we just did, but right at this point, right at the LVOT. And we will then get a graph, and hopefully some of this is familiar. If you saw the continuity equation video earlier, we'll see a graph something like this, where again our y-axis is meters per second, x-axis is second, and now we might see a lower velocity, like 1 meter per second, and the area here, this might just be 25 centimeters. And why are we seeing these two different values? Again, think about a hose where you're pinching it off. The blood has to go much faster at the narrowest point, which is where the stenotic valve is. And so if I measure the velocity at this point right here, right at the LVOT, I'll see that it's going at 1 meter per second. But if I were to measure it right in the middle here, where it has to race through, I'll get a much higher value of 4 meters per second. And if I was to measure it later, I might see again that it's moving at a slower velocity. So we measure the velocity both at the narrowest point and right before that in the LVOT. And then we also do need one additional data point from our peristernal long view. Got the left atrium emptying into the left ventricle. I've got my LVOT right there, and then my right ventricle, and I'm going to measure this dimension right here. And let's say that that was, for math's sake, let's say that that was 2 centimeters. Then I can say that my flow, in the LVOT is equal to my flow right through the narrowest point of the aortic valve. Or I could say that my volume, the volume of blood in the LVOT is equal to the volume of blood right through that narrowest point of the aortic valve. And what would the math look like? The flow would be 1 meter per second times the area, which is pi r squared, but I said my radius is 1, so pi times 1 squared would be the area. That is equal to my unknown times my unknown area times the velocity, which I said here was 4 times 4. In other words, I'll have that pi over 4 equals my unknown area. Or if I use the volume method, what's the volume of blood that flows through the LVOT? Well, that is the VTI times the area. So that will be pi times 1 squared times, I said my VTI was 25. That must be equal to my unknown times my VTI through the stiff aortic valve was 100. And so I can say pi times 25 over 100 is pi over 4. I picked the numbers so they would be the same here. But usually they should be quite close, even without special numbers, equals my unknown area. So this was just a quick review on how you can use the continuity of the conservation of flow or conservation of volume, the continuity equation, meaning the flow or volume that's in the LVOT is the same flow that is accelerating through the stiff valve, to calculate the valve area. And so there's a couple numbers that are helpful to keep in mind. There's 3 numbers in particular. So for your valve area, and then Vmax, the maximum velocity, and the mean pressure, we'll say the pressure gradient mean pressure gradient. The numbers that you need to keep in mind are 1, 4, and 40. Now, keep in mind, with Doppler, we can only measure velocity. And so what you will measure velocity, and if it is 4 meters per second plus, that corresponds to severe aortic stenosis, if it is over 4 meters per second. And from the Vmax, you can do 4v squared to get your peak pressure gradient, or your computer can figure out the mean gradient for you, which will correspond to about 40. But this is with the Bernoulli equation. Our convention is to go off the mean gradient. That's why I didn't write 4 times 4 squared, which would be 64 for the peak gradient. But you could look at it in terms of peak gradient as well. We just, by convention, look at mean gradient, millimeters of mercury. And you can use your continuity equation, that's conservation of flow or mass, continuity, to get your area. And we'll say if your area is less than 1 centimeter squared, that is severe aortic stenosis. How about moderate or mild? Moderate would be if you have an area that is 1 to 1.5 centimeters squared, and mild would be if you have an area that is 1.5 to 3 centimeter squared. And if it's more than 3 centimeters squared, that is normal. But we really typically care about severe. And again, the one that you are measuring with echo directly is the velocity. If it's more than 4 meters per second, severe. And you use the velocity with Bernoulli to calculate mean pressure gradient, with continuity equation to calculate aortic valve area. Now, a couple things to keep in mind as you're doing these measurements. One, let's say you think the patient has severe aortic stenosis, but the Vmax is 3.5, or it's not quite 4, but you suspect it's actually severe. One is make sure you're measuring in multiple views. So measure Vmax in multiple views. Why? The apical 4-chamber view that I have drawn is not always, it depends on the orientation of their heart, that is not always the view with the highest gradient. In some patients, other views, like the right peristernal view may actually yield a higher gradient. And whatever is highest is likely true. Remember, it all has to do with how parallel your Doppler signal is with the actual jet of blood that is accelerating. If it's perfectly parallel, accurate. But if you're measuring at an angle, 30 degrees, 60 degrees, God forbid 90 degrees, where you'll get nothing, then it is less accurate. So that's number one. Measure in multiple views to make sure you're getting the highest velocity. Number two, if your Vmax is not 4, but you think maybe it should be, then there's two scenarios to be aware of. One, if you have a reduced ejection fraction, there may be too little blood flowing across the valve for you to actually have a fast flow of blood and to generate a gradient. And so in that case, we can use dobutamine to try and get the heart to squeeze better. And with the better squeeze, we see if we can hit that 4 meters per second, which then will lead to the mean gradient of 40 and the area of less than 1. So that's if the ejection fraction is low. Another thing to keep in mind is if your stroke volume index is less than 35. In other words, if you have a small left ventricle, same issue. You just may not have enough blood flowing out of that aortic valve to generate that high velocity and the pressure gradient, just because by nature of it being a small small left ventricle small left ventricle cavity size. And so in that case, what you can do is you can try and use other data points. Specifically, you can look at a CT scan and see how much calcium there actually is on that aortic valve. And if there's a significant amount of calcium, then it could be that this patient has severe aortic stenosis. So just to recap from the beginning, different types of aortic valves, whether it's unicuspid, bicuspid, tricuspid, or quadricuspid. Most often we'll be dealing with tricuspid, although we'll see a fair bit of bicuspid. And you can use your Doppler to measure the maximum velocity through the stiff valve. And we can use our continuity equation and Bernoulli equations to go from our Vmax to an estimated valve area and a mean pressure gradient. If our numbers don't quite add up and we think it's severe, but the Vmax is less than 4, make sure that you're measuring in multiple views in case you weren't lined up nicely with your Doppler angle and your Doppler and the Vmax jet. And if the squeeze of the heart is low, maybe you can give some dobutamine to help generate a good squeeze, and then maybe that will generate enough flow across the valve to get a Vmax and the pressure gradient. Or if it's just a small left ventricle leading to less flow, giving that more dobutamine won't help. It's already squeezing well, it's just too small. In that case, you can look at the CT scan for some additional, to try and help figure out if it's severely stenotic or not.